Hello everybody. Today we are going to discuss about the critical care weakness. It includes critical illness polyneuropathy, acute myopathy of the intensive care, critical illness myopathy, the syndrome with the features of both. So risk factors for this is sepsis, multi-organ dysfunction syndrome, systemic inflammatory response syndrome, hyperglycemia, older age, female sex, immobilization, malnutrition, corticosteroid, neuromuscular blockage, and adrenergic vasoreceptors. Pathophysiology is though critical illness myopathy, polyneuropathy, and polyneuromyopathy are present similarly clinically within the same patient population. There is a difference between the underlying pathophysiology, and sometimes the electrophysiological changes found during testing can occur within the hours of admission to the ICU. So we'll see pathophysiological changes. So these are mainly microvascular, which occurs because of the microvascular alteration, metabolic alteration, electrical alteration, and bioenergetic failure. So microvascular alteration is occurring in the conditions like sepsis. So in condition like when there is vasodilatation, increased vascular permeability, which leads into the endoneural edema, hypoxemia, extravasation, and cytokine production. Then there will be metabolic derangement alteration, which occurs because of hyperglycemia, hormonal imbalance, uh, hypoalbuminemia, amino acid deficiency, and activation of proteolytic pathway. Electrical alteration is occur because of the ion channel dysfunction, cell depolarization, cell inexcitability, altered calcium homeostasis, and changes in the excitation contraction coupling. Then finally, it leads to the bioenergetic failure because of the antioxidant depletion, reactive oxygen species, rise in reactive oxygen species, mitochondrial dysfunction, and apoptosis. So exact mechanism of axonal injury is unknown, but one proposed mechanism of injury is microcirculatory changes associated with systemic inflammation, increased production of cytokine, nitric oxide, and other reactive oxygen species, resulting in the changes to anaerobic oxidation, which leads to the changes in the distal nerve ischemia and degeneration. A second proposed mechanism of neuronal dysfunction in CIP is related to the increased vascular permeability with increased leukocytes within endoneural space and formation of edema. As with the central nervous system, hypoalbuminemia and hyperglycemia can worsen the edema. Sodium channel inactivation resulting in the rapid hypoexcitability of peripheral nerve has been implicated in the pathophysiology of nerve dysfunction. Then lastly, bioenergetic failure. Insufficient oxygen supply to the mitochondria may compromise mitochondrial energy production. However, mitochondrial dysfunction in the critical illness appears explained by the impaired oxygen utilization due to direct mitochondrial damage, which further aggravated by inflammation, hyperglycemia, free radicals, and rather by impaired oxygen delivery. So dysfunctional mitochondria not only compromise energy provision, but also amplify the production of the free radical and reactive oxygen species, eliciting vicious cycle of macromolecular and organelle damage. So the diagnosis is made via electrodiagnostic study. History and clinical examination may be able to differentiate between these disease entities like critical illness myopathy, critical illness polyneuropathy, or combination of these. Typically spares the bulbar muscle, lack of autonomic instability, and they do not result into the pupillary changes. So we'll see what is the diagnostic criteria for both. So critical illness polyneuropathy, it happens into the critically ill patient, especially sepsis, multi-organ failure. Limb weakness is present. There will be difficulty in weaning from the mechanical ventilatory support with exclusion of cardiac and pulmonary causes. Electrophysiological evidence of axonal sensory motor neuropathy. Other causes of acute neuropathy should be excluded. For example, porphyria, acute massive intoxication of heavy metal, and vasculitis. Then critical illness myopathy. For this, patient may not be critically ill, but it is exposed to the variable combination of neuromuscular blocking agent and corticosteroid in setting of sepsis and multi-organ failure. So limb weakness is present in this. There will be the difficulty in weaning from mechanical ventilator support with the exclusion of cardiac and pulmonary causes. Electrophysiological evidence of trigger sensory response, reduced motor response, normal repetitive nerve stimulation, and EMG with short duration, low amplitude motor unit potential with early full or normal recruitment of motor unit activation potential. Muscle inexcitability with the direct muscle stimulation. Muscle biopsy will be consistent with myopathy and myosin loss. In CIM, the most common electrodiagnostic finding is reduced compound muscle action potential amplitude, typically below 50% of lower limit of normal. Some of these patients have increased action potential duration. This finding can be within 72 hours of admission, and on serial examination, this finding can worsen. Sensory nerve action potential are usually normal in CIM, but abnormal results are maybe due to coexistent neuropathy or common confounder in ICU like temperature, edema, and recording cycle. Decreased muscle excitability is also typically seen in CIM. In case of critical illness myopathy, the ratio of maximum muscle action potential of the nerve stimulation to direct muscle stimulation was 1. And in CIP, the ratio is more or less than 0.5. Slowing of the direct muscle action potential is correlated with the more severe critical illness myopathy. Standard needle electrode examination reveal positive waves, fibrillation potential, or both in 71% to 100%. Motor units are short with low amplitude and polyphase. In critical illness polyneuropathy, the finding resemble length-dependent axonal polyneuropathy with loss of amplitude of both sensory nerve action potential and compound muscle action potential without significant slope. These changes are worse in the leg than in arm and typically violent. Although they need not necessarily be symmetric. The initial finding of CIP occur by week of 2 of critical illness, but have been reported as early as 72 hours from the admission to the ICU. Standard needle examination reveals fibrillation potential and positive waves in distal and proximal muscle, which typically occurs within the 2 weeks of illness but can be seen as early as 1 week. Motor unit potential demonstrated decreased recruitment and morphology changes consistent with the timing of the study. Interestingly, the fibrillation potential can also be demonstrated within the facial musculature. Respiratory failure and inability to wean from the ventilatory support are common symptoms of critical illness acquired weakness, and examination of the phrenic nerve and diaphragm can assist with the diagnosis. Diaphragm EMG can show fibrillation, positive sharp waves, and the reduced number of motor unit potential. Phrenic nerve conduction can demonstrate either prolonged latencies and reduced motor unit action potential. Limited diaphragmatic excursion during spontaneous breathing trial is consistent with the diaphragmatic weakness, but is not limited to the weakness acquired in ICU. Although useful for diagnosis, diaphragmatic EMG remains technically challenging within the ICU setting. With known limitation of the nerve conduction studies within the ICU, muscle biopsy may be useful for definitive diagnosis. The typical pathophysiological finding in CIM include relative selective loss of myosin and loss of type 2 greater than type 1 fiber. Muscle biopsy in the critical illness polyneuropathy will demonstrate features of denervation and reinnervation with small muscle fiber type grouping and fiber group atrophy. Now biopsy in the CIP will demonstrate widespread axonal degeneration of both motor and sensory nerve. Muscle biopsy in the critical illness polyneuropathy can have features of both CIM and typically thick filament loss and CIP with denervation and reinnervation changes, and now biopsy have axonal degeneration. Differential diagnosis of acute neuromuscular weakness commonly include GBS, metabolic neuropathies, toxic neuropathies, and neuropathies due to nutritional deficiency. The GBS is the autoimmune disease of peripheral nervous system, usually presents as symmetric, progressive, and ascending paralysis, sensory abnormalities, and areflexia, and 30% of patients require mechanical ventilation. So we'll see what is the difference between the critical illness polyneuropathy and GBS. Critical illness polyneuropathy is mainly occurring to the sepsis and multi-organ failure. The onset of disorder usually after intensive care admission. It is often characterized by the fairly symmetrical limb muscle weakness, sparing cranial nerve. A sensory deficit will be less prominent. So a CSF fluid study will be normal and electrophysiology will show axonal, motor and sensory polyneuropathy. MRI won't show any significant finding. In biopsy, there will be primarily axonal degeneration of distal peripheral nerve without inflammation. Treatment is not specific, usually antiseptic treatment. Recovery may be spontaneous and variable timing. 50% of the patient will fully recover. In GBS, there will be predisposing gastrointestinal respiratory infection. Onset of disorder will occur usually before ICU admission. Infection precedes the onset of progressive weakness and sensory disturbance. There will be frequent cranial nerve involvement. There will be albuminocytological dissociation. Demyelinating polyneuropathy and unresponsive nerve and abundant spontaneous activity. Axonal motor and sensory polyneuropathy. There will be occasional enhancement of the spinal nerve root. Then biopsy will reveal a demyelinating process with inflammation or motor sensory axonal degeneration or motor axonal degeneration only. Treatment will be by plasmapheresis and intravenous immunoglobulin. Usually more than 75% of patients will show complete recovery. Now we'll see what are the causes of generalized weakness in ICU. So if it is muscle disorder, acute myopathy of intensive care, inflammatory myopathies like myositis, polymyositis, dermatomyositis, myopathy secondary to the dyselectremia like hypokalemia, hypophosphatemia, rhabdomyolysis, muscle dystrophy, mitochondrial myopathies, acid maltase deficiency, pyomyositis, and periodic paralysis. Neuromuscular junction disorder includes neuromuscular blocking agent-induced weakness, antibiotic-induced myasthenia, myasthenia gravis, organophosphorus poisoning, snake inflammation, insect and marine toxin, Lambert-Eaton myasthenic syndrome, congenital myasthenia syndrome, hypermagnesemia, botulism, and tick paralysis. Peripheral neuropathies include critical illness polyneuropathy, GBS, chronic idiopathic demyelinating polyneuropathy, phrenic neuropathies, toxic neuropathy, porphyric neuropathy, vasculitic neuropathy, diphtheria, lymphoma, cytomegalovirus-related polyradiculopathy. Anterior horn disorder include amyotrophic lateral sclerosis, paraneoplastic motor neuron disease, West Nile virus infection, spinal muscular atrophy, and acute polymyositis. Then the spinal cord disorder include trauma, hematoma, spinal cord infarction, epidural abscess, multiple sclerosis, infective myelitis, and paralytic rabies. Then brain pathology include cerebrovascular accident and then multiple sclerosis, acute disseminated encephalitis. Now the treatment part will be consisting of the nutritional therapy, antioxidant therapy, hormonal therapy, intravenous immunoglobulin, insulin therapy, and physiotherapy. So far, no specific therapy and only preventive and supportive measures have been shown to be beneficial in the management of critical illness, polyneuropathy, and myopathy. The measures include aggressive treatment of sepsis, reduction of the dose, duration of neuromuscular blocking agent, corticosteroid rehabilitation program, careful positioning, nutritional intervention, antioxidant therapy, testosterone derivatives, growth hormone, and immunoglobulins. As hyperglycemia is the risk factor for critical illness, polyneuropathy, and myopathy, strict glycemic control with insulin should have beneficial effect on patients. Studies have shown that intensive insulin therapy for hyperglycemia lowered the risk of critical illness, polyneuropathy, and myopathy, and decreased the time on ventilator support. The duration of intensive care unit stay and 180-day mortality rate. The insulin is associated with some potential benefit effect, including anti-inflammatory effect, endothelial protection, improvement of dyslipidemia, neuroprotective effect in animal, and is also anabolic hormone. Despite its effectiveness, intensive insulin therapy increases the risk of hypoglycemia. And investigators found that strict glycemic control increases mortality among adults in the intensive care unit. Other studies have indicated that incidence of weakness or failure to wake did not decrease and that no improvement in the muscle strength was achieved by strict glycemic control. Early rehabilitation, combining mobilization with physiotherapy, is emerging as an important strategy to treat critical illness, polyneuropathy, and myopathy, and to facilitate and improve long-term recovery and functional independence of patient and shorten the duration of ventilation and hospitalization. Electrical muscle stimulation is a form of exercise and mobilization and that does not require patient's active participation and can thus be applied to the mobilized patient. So electrical muscle stimulation has been shown to be beneficial to patients with chronic heart failure and COPD disease, as well as intensive care unit and hospitalized inpatient. High-dose parenteral glutamine supplementation reduces the complication from infection and shorten the length of hospital stay. Early treatment with IVIG at the time of diagnosis of sepsis has been suggested and examined in few small studies. Whether this can mitigate the development of CIP or CIM remains uncertain, but has been suggested as a possibility. IVIG would seem unlikely to be specifically alter the pathogenesis of CIP or CIM, since these entities are believed to be primarily caused by toxic insult rather than being immune mediated. Recombinant activated protein C has been shown to reduce the morbidity and mortality in septic patients, while it is tempting to infer that it may improve outcome in CIM and CIP, and its role in this has not been specifically addressed. Thank you.